Good morning and welcome again. My name is Lauren Rock and I'm President and CEO of Montefiore and the Weils, and we are just so thrilled that you're here. We'd love to thank the Mount Sinai Healthcare Foundation for their support in helping us deliver this program, and as well as Medical Services Company who helped support the breakfast. I have the pleasure of introducing Dr. Lori Stevic-Rust, who we fondly call Dr. Lori. Dr. Lori Stevic-Rust is a board-certified clinical health psychologist who holds a doctoral degree in psychology and earned a diploma from the American Board of Professional Psychology. She completed an internship at Henry Ford Hospital with specialty training in geriatrics, cardiac care, and integrative medicine. She is a national healthcare consultant for Art Tower Advisory Services and director of senior services for Lake Health Hospital. She's president of the Lake County Council on Aging and serves on the Professional Advisory Board for the Alzheimer's Association and the United Way. And for us, she is a program and design consultant for Montefiore and the Weils programs and environments, and works with our staff and family and education and support activities. And we're very grateful to have her part of our team. Over the past 20 years, she has been a regular on-air television and radio contributor. She writes a Dr. Lori column for several national magazines and is a regular blogger for the Huffington Post. And with that, I'd like to welcome Dr. Lori. Thank you.
Thank you, everybody. I'm not usually great up here at the podium, and I do apologize for the delay. You know, when your clock is set for 11:15, but it goes off at 11:45, that's not a good sign. So I'm going to put my disclaimer out there that, to my knowledge, I don't have any cognitive deficits, but the jury is still out for the day. So again, I apologize for the delay. I don't mean to be disrespectful to your time. So with that, I'm going to go ahead and launch in to talking a little bit about dementia. Now, I know that that's the symposium in general, but one of the things I've been tasked to discuss today is some of the behavioral and more of the psychological components to dementia. We typically think of it being simply a disease of cognition, but one of the things that I have found over the last 20 years is that the most difficult symptoms and behaviors for families and caregivers to provide services for is more of those ancillary psychological and behavioral components. So with that, I'd like to start out first, and for those of you who've heard me speak before, this is the one message that I always say: if you don't hang on my every word, which I know you all will, but if you don't, my hope is that you will leave with one specific thing in mind today. And that is, I'm often asked, what's the distinction between dementia and Alzheimer's disease? And for those of you who are care providers, you know the answer is, it's the wrong question. The question is really, does my loved one have dementia? Because dementia is not a disease. Dementia is a disorder and a description. Dementia simply means difficulties with cognition, deficits that were specific to short-term memory, attention and concentration, comprehension, reasoning, the inability to sequence steps, impaired problem solving. So once we determine if somebody actually has those deficits, has the dementia disorder, then we have to go searching to find out what is the cause. And for most of you who are clinicians out there, you know that the first and foremost thing that we always have to do when we're making a clinical diagnosis is to rule out those things that are treatable. Oftentimes, if an 80-year-old perhaps comes into an office and the family members say, you know, my mom is experiencing some confusion, or we've noticed that my mom's short-term memory is not what it used to be, unfortunately, sometimes we make a huge leap to say, well, 80, short-term memory loss equals dementia. But sometimes short-term memory loss and confusion can equal an underlying treatable condition. So that's where you see that we have the condition called delirium. Many of you have probably heard of the word delirium. There again, that's a description that simply means there's an underlying etiology that is causing the changes. Delirium is an acute onset condition. It waxes and wanes very quickly. And some of the underlying causes that we go searching for when somebody presents with dementia-like symptoms is things like thyroid disorders, electrolyte imbalances, metabolic conditions, infections, things that we know that particularly in our seniors can present looking like dementia, but may very well be that underlying medical condition that if we treat it, we can sometimes see the symptoms either improve or completely be removed. So I always have that in my decision tree here, that delirium is one of those most important things that we rule out. After we talk about dementia, we're then left to say, okay, what's the underlying cause of the dementia? So if my loved one does have the condition, what's causing it? There are over 100 different kinds of diseases that causes dementia. The number one and most prevalent, of course, is Alzheimer's disease. But we also have conditions like vascular disease that can cause dementia, Huntington's disease, Parkinson's disease, a number of other neurological conditions, alcoholism. There's a specific condition called Lewy body disease. We're hearing a lot more about frontal temporal dementia. So it's again important for us, thank you all for coming. No. It's important that we recognize what that condition is, because at the end of the day, as clinicians, we have to be able to track the progression, put together the best care package and care plans early on in the diagnosis of the condition. And what we might be doing for somebody with Huntington's disease might be very different than what we're doing for somebody with Alzheimer's disease. This is one of my favorite graphics here, and I wish I could just keep replaying it over and over and over, so I might. Whenever I'm doing training with clinicians, the first thing I really talk about, or even care providers in a home setting, is it's one thing for us to talk about an intellectual understanding of dementia. And probably all of you have that out there. It's another then to translate what we know about this disease and put it into a care plan. Because to have the look of somebody and say, well, my dad doesn't really remember, I know he has dementia, but it makes me so angry when he's rude to people, or I'll say to him, Dad, I told you that already. It's as if somewhere in there we see Dad's face and we forget that underneath all of that is a brain that is beginning to have disease. With dementia, let me ask, first of all, for my audience here, how many of you are clinicians who work with dementia? How many of you are family members who are providing care to somebody with dementia? Okay. So most of you know that when we're talking about dementia, regardless of what the etiology is, it usually begins right here in the hippocampus of the brain. And what the hippocampus is responsible for is two primary, well, for a lot of things, but we'll say for simplicity today, two primary functions. One is language skills, and the other is short-term memory. So what is the first thing that you usually see when somebody comes into your office and it presents themselves with this condition is they struggle with language. Now, early on, we do this thing called confabulation, where we can talk around it. So that subtle change where family members might say, you know, my dad, he seems to be doing okay, but when it comes to specific words, he won't be able to really retrieve those. Now, for those of you who are sitting there panicking, thinking, oh my God, that's me, I can tell you that with aging, we know that we lose some of that. It's right on the tip of our tongue, right? Because with a normal aging brain, the brain does shrink. We do lose the ability to think as quickly. The neurons don't fire like everything else in our body as rapidly as it used to. So we will find that sometimes the words aren't quick to come. Maybe we have to make more lists than we ever had to in our 20s and our 30s because we easily get distracted, or we don't find that the ability to multitask is as good as it used to be. And for those of you who are of a different gender, and I apologize in advance, but the research really shows this, men are really premorbidly not very good at multitasking, and so with aging they get much worse. One of the things that we know then is when we have somebody who's struggling, and this disease begins right here with language and short-term memory, and remember, short-term memory is really clinically defined as a loss of an ability to remember information in a very short window of time. So that could be anywhere from 30 seconds to 2 minutes to 4 minutes. So when people say, you know, but my memory's not as good as it used to be, but give me a little time and it comes back to me, that's the difference between normal changes related to aging versus disease states. Now, when we talk about the behaviors that go along with disease, I always use this graphic to say, typically the disease starts here, but what if the disease for your loved one, or for Mrs. Smith, spreads to the back area of the brain? Versus Mrs. Jones, where the disease may spread to the frontal area of the brain. You have a very different picture. So sometimes people will ask me, is my loved one in the mild, moderate, or severe stages of the disease? Now, with all respect for the need for categorization and the fact that the literature talks about those areas, I have a hard time clinically putting those into practice. Because what does somebody in the moderate phase of the disease look like? Is that somebody who is quiet, but doesn't know where they are, doesn't recognize family members? Or is somebody in the moderate phase the person who is acting out, aggressive, hitting somebody, but has the pretty good language skills still intact? And the answer for me consistently comes back to they're both probably in a more advanced stage of the disease, but it doesn't help me at all when it comes to care planning. And the purpose today, I think, for you is to really look at understanding the disease only works if we translate in our day-to-day care. Otherwise, it's just an intellectual understanding of a condition. So I come back to my graph again and I talk about if this disease, because particularly with Alzheimer's disease, we know that it spreads. It spreads in very random patterns. So even when you do cross sections and you look at brain slicings, no two brains look exactly the same with the disease. If this disease continues to spread back in this area of the brain, this is where we would expect somebody to be more at a fall risk. Perhaps their balance is more unstable. We might expect them to lose the ability to manage information in space, so the 3D manipulating objects may be gone. Versus somebody who the disease starts here and spreads to the frontal lobe. Now, that's probably where the rubber meets the road in this conversation, because the frontal lobe is the area of our brain that is responsible for higher level thinking, higher level functioning, problem solving. It's where our judgment sits. It's where much of what our personality is all about. It's also about where our impulse control is. So we all know those cases that become the most difficult, which is where family members will say, my dad used to be a really proud man, proper. And yes, he can't remember. And yes, he gets confused. But the hardest part for me as a daughter is when he is being sexually inappropriate to the nurses, or he is taking his clothes off in the hallway, or he's using language that I've never heard my father use before. Those are the kinds of stories that we hear that's really all about the pain of when the frontal lobe becomes damaged. This is where people become more aggressive. The behaviors for us to manage on a unit becomes more problematic. When impulse is gone and judgment is gone, you say what you think, you do what you want, all in the moment. It is our frontal lobe that when we're thinking what we really want to say to our boss is X, and then that part of our brain goes, oh, but wait a minute, you got a mortgage to pay. It clicks in and your judgment goes hand in hand, and our impulses are better controlled. So this is the area, particularly now, even where we're beginning to see things like frontal temporal dementia coming more into the foreground. We're talking about it more clinically. Some of that is also because of the literature that we're understanding about people with post-concussion syndrome. And several years ago when the NFL started to talk about diseases that were happening to our professional athletes after they've sustained numerous concussions, it is this area of the brain now that we're just beginning to understand it's not about just Alzheimer's disease spreading there. There's a specific entity called frontal temporal dementia that has some of its roots into damage to the frontal area of the brain, and oftentimes we see that with people who sustained injuries. So what are some of the behaviors that we're talking about? First of all, again, this is my list. I am certain many of you who are care providers out there have many more. When I gave this talk yesterday to the community that was here, I put these up here and we heard people talking about, but there's also this, and I see my mom doing this and my dad doing this as well. So certainly we know that agitation and anxiety is one of the big problems with this disease state. Depression, pacing, incontinence, masturbation, yelling, picking. I talk about picking because when you're developing an environment, you also want to make sure that there aren't elements in the environment that lend itself to more of the picking behavior. How many of you have ever seen somebody picking at carpeting, picking at their clothing, picking at their skin? And sometimes that's because there is a sense of misperception. It doesn't even have to be hallucinations, but a misperception that that white dot on the rug is something that I need to get to. There's something on my clothes I need to remove. There can also be something called tactile hallucinations that's often consistent with people who have disease that hits certain areas of the brain, where people will talk about the bugs that are crawling underneath the skin and they have to pick and pick and pick to get the bugs out, creating lesions and sores and injuries to themselves. Falls, as we talked about before, spitting, banging, crying, rocking, poking at other people. And of course, the one that we never really want to talk about, but if you go on a unit, the nurses will talk about the smearing of fecal matter, which presents a whole different array of difficulties for managing somebody, not only at home, but on a unit as well. When we look at behavior, I remind people that behavior is purposeful. Even with a damaged brain, the behaviors that we see are coming from some place. There is a meaning behind the behavior. Behavior comes from two places. One, it is a combination of what is happening to the brain. So remember again, this is damage that's occurring. We can't pretend to not remember that. Plus the changes that are occurring in the environment. So with this, I will often say to people, I'd like you to imagine being in a foreign country. You don't understand the language. You're driving down a road and it's dark. And you have two small children in the back seat. And you get to the end of the road, you can't read the signs, can't identify your surroundings, you're lost. And just then you see somebody coming out of a bush, walking towards your car, and your brain does two things. I need help. Do I accept this help of the person approaching the vehicle? Or do I put the windows up and try my very best to get out of here? It's our classic fight or flight. It's as primitive as anything that we know. Can you imagine? Put yourself in that state. What are you feeling? Describe the symptoms. Panic, fear, heart rate's up, blood pressure's up, your stomach's in a knot, you're sweating. We know that what happens during the fight or flight response, the brain actually slows time. So you can absorb what's happening in the moment, get rid of all the extra information that's coming into the brain that's irrelevant, so you can focus on one thing and one thing only. This is an emergency situation. What do I do? Now imagine you're sitting there in that state. You've got somebody approaching the window, and the children in the back seat are saying, "But I'm hungry. I thought you said we're going to get McDonald's." Now imagine again your response. It's probably going to sound something like this. "Oh, honey, in a minute. I know you want those fries. I do too. But as soon as I can figure out where we are and what this guy approaching the car is all about, we'll head to the nearest McDonald's and get you a Happy Meal." Right?
Right.
I mean, come on, how many of you are parents, have been parents of children, right? I don't even have to put you in a foreign land without language ability, right? More likely than not, when you're in a state of panic, your response is going to be, "Shut up! I gotta think! Stop it!" Right? You are not your best when you're panicking, when you're nervous. Excuse me. Now I need water. You're not your best when you're panicking, you're nervous, you're anxious, right? So imagine a resident or your loved one. They don't understand the language that you're speaking. They can't recognize the surroundings of where they are. You are approaching them perhaps, thank you. That screaming about McDonald's did me in. You don't recognize the people coming towards you. Your body is in a fight or flight response. You're scared. Your heart rate's up. You're nervous. You can't make sense of what's happening, and yet you're trying to figure out, do I swing at this person and defend myself? Do I yell for help? Do I try to get away? Do I protect myself? Or is this person really here to help me? That is the state of many of our loved ones who sit in the place that we know as dementia. Our challenge as care providers is then to be able to interpret they're scared. That's why they're anxious. They can't make sense of why I'm coming towards them, even if what I'm coming towards them to do is to assist them in the bathroom or to help bathe them. The challenge consistently relies on the ability of a caregiver to understand this disease, which is why you're all here today, and then to translate this understanding into how you're going to provide day-to-day care. I do this, as Lauren mentioned, across the country, and I'm consistently amazed and impressed by our care providers who work in memory care facilities. Because you are the key to providing the best possible care, and yet you're human. So my challenge becomes, how then do we manage the environment? We have to figure out, like detectives, what it is that our residents or our loved ones need. So somebody who's doing this, I mean, you see this all the time, right? Banging on a table. And care providers who are not well trained or family members who are exhausted and at their wits' end will do what? Why are you banging on the table? Stop doing that. Now, why are you banging? Because, of course, we expect them to say, oh, I'm banging because I have to go to the bathroom and you didn't realize that. Could you help me? Right? If they have the ability to say that, if they have the ability to communicate with you what their needs are, they wouldn't be in the memory care facility as they are. Correct? And yet we forget that. Our task and our challenge is to say, what is driving the behavior? Whether it's this, whether it's the pacing, whether it's the yelling, whether it's the spitting, whether it's the striking out, what is driving that? We call that the antecedent to the behavior. So we have to start searching for what is that. Just before the person started to bang on the table, what did we notice? What did we observe? Was the person sitting at their table and every time they shifted in their chair, they did one of these? We know what a grimace looks like, right? People grimace for a couple of reasons, right? They're uncomfortable. They have pain. If that's happening right before the banging on the table, there's a pretty good opportunity for us to figure out maybe this person is in a lot of pain and what they really require is a change in position, medication, something to manage the pain as opposed to directing to their behavior. How can we get them to stop banging on the table? Because in fact, we don't want them to stop banging on the table if that's their only way to get our attention and communicate their need to us. It could be that they need to be toileted. Maybe that shifting in the chair, there was no grimace, but it was a lot of the squirms, right? Maybe it's fear. Maybe it's fatigue. You know, again, there's always the balance between wanting to stimulate residents, having a lot of activities, making the environment interesting for them because we know boredom, intellectual boredom, cognitive boredom can create a place of distress. But at the same time, being overly stimulated, having too many things to do, no opportunity for rest or relaxation can create the same level of distress. We know that noise in an environment, none of us like to be distracted with a lot of noises, right? You know yourself if you're trying to think, kids talking, colleagues having conversation over here, the TV being too loud, you're on sensory overload. And there again, you're probably not your best. So one of the things when we know that the brain is so exquisitely sensitive, as it is in dementia, when they're struggling very much to hang on to information, a very noisy environment or a chaotic environment can make that confusion worse. We talk about sensory issues, sight, sound, smells, temperature, really critical issues when it comes to managing behavior. Somebody who's cold is not going to be paying attention or sitting still or managing their own selves as well. And then we get down to the most important, which I think of as how do we put the person at the center of care? How many of you have heard the words person-centered care? Give me a sense of what you believe that means. What is person-centered care? Somebody yell it out. Okay, so you're taking into account somebody's personal characteristics, kind of who they were, what their interests, their needs are. Patient's choice. Anything else? So I would, I'm sorry? To make it individualized. And I would say that all of that is true. And yet when we talk about it and you go into a facility and if I say to them, show me your person-centered care plan. How many of you believe that you either in your facility or when you're providing care, you have a person-centered care plan? Okay, what does yours look like?
Well, when we involve everyone in the care plan, we get information from family, friends, doctors, therapists, nurses, anybody who has contact with the patient, they have input and that develops the care plan.
Okay, great. Anybody else say at their facility? Where are you at? Are you here? Where's your facility that you would say you have that person-centered care plan? This is your shout out for your facility.
Oh, university case.
Okay. Anybody else? Yes.
I do home care, so it's a little more difficult because you're dealing with a caregiver and a caregiver's helpers, and you're getting different stories from different people. So yes, we do have to do a care plan that becomes part of our paperwork. But hearing what the patient says and the caregiver says and the helper says are usually nowhere related
Mm-hmm.
to it. So it spend a lot of time and a lot of visits picking things up and playing with your care plan as time goes on.
Right, right. And I would add to that, for me, the core of a good, solid, person-centered care plan is one that is multidisciplinary, because you have to be able to have the eyes of different folks who are doing touch points with the person. So if somebody says, you know, when I am toileting Mrs. Jones, these are the things and the strategies that I know are very helpful for her in managing her anxiety, her agitation, which is equally as important as somebody who says, my dad always enjoyed music. So making sure that music is a part of his plan. Because sometimes I think when we first started talking about person-centered care, it was about rights, which the gentleman up here talked about, somebody's choice, rights and responsibilities, which I think is the starting place. But it's hard to translate that when you're dealing with somebody with dementia who may no longer be competent to be giving you what they want. So we're relying on anecdotal information, pre-morbid information from family members, but we're trying to translate that into strategies of care, and at the same time not ignoring what I've been focusing on from the beginning, which is the disease. Because oftentimes, and I used this example yesterday, I can have people come in and say, now, I know that my dad is having hallucinations, but I do not want him snowed on medicine. I don't want him on an antipsychotic medicine. That's really important to me. And while we want to be very respectful of family members' wishes and ideas, I come back to what happened to person-centered care. And isn't person-centered care about the quality of today? If anybody's ever experienced anxiety, agitation, and hallucinations, you know it's not a very pleasant way to live. So anything, any combination or anything that we can do to alleviate that distress is truly person-centered care, because now, again, it's about the needs of the person and not the needs of the family, not the needs of the institution, and not the needs of the care provider. Now, having said all of that, we know that we can't ignore what's happening to the disease, because a good person-centered care plan is going to have to change, right? You know that the care plan of today may not be the same care plan of next week, because we're mindful of what's happening here. We're recognizing that the person is at the core of that. I have to always do a little plug. That's my 102-year-old grandmother. And then we also have to pay close attention to the caregiver being the key. What do I mean by that? If as a care provider we come at somebody and we say, we need you to remember, or don't you remember, Dad, that I told you we're doing that at 11 o'clock? Now those of you nagging wives out there, you know that when we say to our spouses, remember I told you we're doing that at 5 o'clock. We're not saying that as a compliment, right? There's a little undercurrent of, What's the matter with you? You never listen to me. You never remember anything. Nothing I say matters. There's a little bit of a shaming quality to don't you remember, right? There's a little bit of let me point out to you that you are not paying attention. So I'm going to show you what your deficits are. And while that might be okay in your relationships, it's very difficult to understand how we can say on the one hand that we know you don't remember, and yet we still say, don't you remember, Mom? I told you. Or trying to reason with somebody who doesn't have the ability to reason. And then my all-time favorite, and anybody who knows me knows that anytime I hear a care provider or a family member say where they're trying to really manipulate us, every hair on the back of my head stands up, and that little Italian part of me flares. And I say, okay, how many of you know somebody who's manipulative? Oh, for God's sakes, it should be every one of you, or you've lived a charmed life, right? Put a picture of that person who's a manipulative person. What are they like? Obnoxious, bossy, selfish, overbearing, demanding, hard to be with. And I would add calculating, right? Because if I want to manipulate you, I got to know you. I mean, I can't manipulate this woman here in the front to do anything I want because I don't know her. But if I knew something about her and I knew what buttons to push, I'd be able to do it, but do it with a smile. Because, of course, good manipulators are charming, right? Right before they come in for the kill. So I would have to know a little bit of something about you. Now let's go back to how does the brain process that? I got to think about what buttons to push in you. I got to figure out how to get what I want from you. There's a whole strategy. And if I broke that down in step by step, we're talking at least 17, 18, 19 steps to be a really good manipulator. So how then can somebody who we've recognized as having difficulties, damage, change to a brain, be manipulative? Now, I know I get pushback when I say this because I'll have some sons or daughters say, but my mom always was a manipulator her whole life. So the old lady you see sitting before you is still the same lady who could manipulate with the best of them. Now, that might be true. But this is one place when I say bringing in the history or their premorbid functioning has no place. Because if I'm providing care to your mom, I don't really care that she was manipulative to you in your lifetime or how she managed things. I care about one thing. She's trying to get my attention. She has a need right here in this moment that I have to take care of. And if you want to put the label of manipulative on it, it has a connotation and a spin that almost gives us permission as care providers to go, well, she's just manipulating, and we write off the need. We're human, right? So really important that we are able to lean in and stay present as care providers with somebody who has a difficulty expressing and conveying to us what their needs are. When I talk about the caregiver being the best tool, because sometimes I'll have people say, what are the best things that you should have in an environment to provide best possible dementia care? And there's a list of things. Sometimes I'll be asked, what's the best assessment tool to really be able to delineate if somebody has dementia? And there are those things as well. But at the end of the day, the most powerful tool that we have is a care provider. Because it is your face, your body, your movement that will dictate the person's behavior, how they respond, how they convey their needs, and how they communicate. It's entirely about the nonverbal. So back to my story about the stranger approaching our car. What would you be looking for to decide, I'm trapped, I'm in a dead-end road, I need help. Is this person coming to my car window somebody that I can trust? How are you going to know?
Body language.
Body language, what are you looking at?
Are they looking tight? Are they making a face that's not a friendly face? Are they walking in a certain manner that is not a casual stroll?
Okay, so you're looking at the pace of which they're approaching you. You're looking at their face. Do they look friendly? Do they look threatening? What else? Excuse me?
Are their hands empty? What's in their hands?
What's in their hands? Yes.
Whether they're picking up on your fear, and how they approach you.
right? Are they responding to that? Like if they think you're fearful, are they going to take advantage of that? Or are they trying to do something to soothe you, to disarm that fear? So I come back to, again, as care providers, and when I'm doing the training, I'll say to people, I get it that you're human. I get it that this is hard work. I think there couldn't be any harder work in healthcare than there is to provide 24-hour, on a locked, secured unit, care to people with dementia. And I've worked in the acute care side. My hat has always been off to my ICU nurses who work under tremendous pressure. There are great places that there's true champions across the board in healthcare. But I think there is nothing more challenging than trying to communicate and create a good quality of existence than there is with somebody with dementia. Because what happens? You come into work, but you've maybe had a fight with your kids for the umpteenth millionth time. You get into work, you're a little bit late, you're frazzled, and it's all over your face, right? Because you're human. Now you come in to give Mrs. Jones a shower, and she took a swing at you. And you're thinking, well, Mrs. Jones likes me, because we want to be liked as care providers, right? Can't understand her behavior. That's when I'll say to care providers, and what was happening to you? What did your face look like? Were you so distracted that you weren't aware of what was happening externally? So we have this saying about pause, reflect, and heal. And it's a tagline that I put signs outside. As Lauren mentioned, I'm the senior director for Lake Health. And when we try to look at how can we really provide better care through the whole continuum for seniors, we thought about a strong message to every care provider before they enter a patient's room. So outside we have plaques that say, pause, reflect, heal. It's a reminder for all of us to take a deep breath, pause, realize that our best therapeutic tool, it's not your blood pressure cuff, it's not any of the other items that you might have as a healthcare provider, it's you. Realizing that when you enter that room, everything about the way you approach, the way that you look, the tone in your voice is your therapeutic tool. Okay, I'm just going to end here with a quick little overview about some therapeutics. Can I have a time count? Okay, I'm getting the 5 minutes, so I'm going to wrap this quickly because I know last time we had a lot of questions and I want to be respectful of answering any questions that you all might have. So one of the things that we know in a therapeutic environment is to make certain that we're seeing the environment through the eyes of the person with disease. What do they need? What happens when somebody is no longer able to interpret in a room? When there is high glare on a floor that makes it look like there's puddled water? When there is dark carpeting that abuts to light carpeting that gives the sense that if I step into that place, I'm stepping into a hole, it's frightening. Lots of environments today are very, very sensitive, from working with architects through development and design with a team to make certain that we're very mindful that the environment isn't just aesthetic. Because you can have beautiful facilities that you put a lock on a door that does not make it a memory care unit. So this is one of an example of a snoozeland therapy room that I put together years ago for a facility. How many of you have heard of snoozeland therapy? It is actually a multi-sensory room. But here again, my challenge is the room is only as good as it is for those people who are using it. Lots of facilities will say, oh yeah, that's our multi-sensory room over there. Well, what do you do in there? Kind of nothing. Or on occasion, if somebody's agitated, we'll walk them in there. My challenge is you have great creative ways to create a room that is all about the senses. When you enter this room, you don't have to understand anything. You're experiencing through the senses. Sight, sounds, smells, music. Because one of the things we know that with dementia begins at the cortical level or on the surface level of the brain. Deep inside the cortex is where our ability to interpret music. Deep inside is where our long-term memory sits. And our ability to experience our environment through our senses, because it's not cognitive, it's not intellectual. So for many people, when we say, well, but what can we do? With all of the deficits and the diseases, how can we connect with this person? It's to find a way to reach deeper in the cortex. And my suggestion has always been, find a way to reach the senses. Music is one of your most powerful second tools next to being the care provider. Looking at ways that your environment and your programs can tap into the long-term memory. I mean, just looking at this reminiscent room, I'm sure you all have an image, right? It's either of your old kitchen, your grandmother's kitchen. It conjures up memories, it conjures up thoughts, it hits into the long-term memory bank. All right, with that, I'm going to pause because I'm getting the 4-minute sign and I want to be able to answer any questions that all of you might have. Oh, come on. The entire community yesterday had, yes?
What was that big white ball in your sensory room?
It actually, well, how many of you remember the 70s? It's a disco ball. But really, oh, this was interesting because what I ended up doing is this is a ball that could twirl, but once you learn your residents, you know that for many people, if you have a lot of people with vertigo or balance issues, you don't want a ball that's twirling. So what we did was we found a way to reflect light to create the sense of stars by reflecting off of the ball. This is actually a wheel. It's a sensory wheel that you can purchase with materials that has images of clouds. So when you're sitting in here, the clouds are moving, the stars are reflecting, which creates more of a soothing environment. So if I put lavender in the room, I infuse music that is of a lower tempo. And what we did when we put this room together, we actually did some research to find out what are the elements that were truly useful. And so this environment set up in the late afternoon, early evening. If you brought somebody in, sometimes at least 15 minutes per every 3 hours, you could really see some changes in sundowning. Because as many of you know, sundowning is that period late afternoon when people get very anxious and restless. But if I have somebody that I want them to be stimulated and alert, I want them to be able to eat. Because we don't want somebody drifting off to sleep when nutrition is important. You can change this environment around by changing this wheel. There are other images, like on this one, I could change this to a forestry scene where you would have animals, something that's cognitively more stimulating, where you have to actually watch and pay attention. And you could change the lighting, change the smells, because we know that orange is a very stimulating sensation. So you infuse a different smell in here and you change the tempo of the music, because the neurons in the brain mirror the musical tempo. I mean, think about that yourself. That's why, for those of you who have rhythm, when you're dancing, it's your neurons beating to the same path and beat of the music. So if you want somebody, you know yourself, if you want to kind of just chill out, you're probably not putting on, I'm not going to give a title because that's what ages me. I said John Bon Jovi and everybody looked at me like, really? But you're not putting on something that has a high tempo beat, right? If you want to be relaxing. You're putting on something that's a little more mellow, maybe meaningful to you. So we know that music, just in its tempo alone, can be useful in rehab units when you're trying to work with somebody with dementia and you can't cognitively give them instructions. You can use music to keep the tempo, to keep the rhythm of the steps that you want them to do rhythmically. So there's a lot of great strategies if you're mirroring what's happening to the brain to the therapeutic process. And this room gives you that flexibility. Yes, ma'am?
I was going to say, how tall are the ceilings in that room?
This room was, actually it looks a little deceiving. It was a 10-foot ceiling.
Oh, okay.
Yes.
What are your recommendations for caregivers that are still in the home taking care of people? Because you've got a lot of stress, agitation, frustration, and for us to sit down and say to somebody, or even the family members that come into a facility, well now, don't forget, that's not you they're angry with, this is the disease, and a lady almost hit me one day because I told her that.
Mm-hmm.
So what are your recommendations for families, whether they're coming here or
Yeah.
other facilities, or they're in the home?
Well, and it's a great question, and oftentimes, as you probably know better than most, it's usually one family member who is the care provider, and it's usually the daughter. And I'm sorry, I know we have some great gentlemen out there who are providing care as well, but if you look at the numbers, it's usually the daughter, it's usually the local daughter, and it's usually the local daughter who carries the brunt of it. And so one of the things that I say, if at all possible, is to get the whole family together in front of care professionals to be educated. Because the best thing you can do to support a care provider who doesn't reach a place of wanting to strike you, like, all right, I've heard that 9 million times, but I haven't slept and I don't want to hear it again, is to make sure that they have a team. This really takes a village to manage these kinds of behaviors, this disease. And the village can be within the family, within the network in a community, within an agency. it's really about support systems. And so the first thing I would say is making sure that the family is well educated, not just in the moment of hearing it. Then I would move on to safety is our second most important thing in a home, right? Are they safe? Because if you don't understand the disease and you say, well, my dad would never go out that front door, he's never done that, then they don't understand that what they did on Tuesday may be very different than what they do on Thursday. So it's about safety. It's about making sure that they understand if you're going to keep them in the home, here are the strategies that you need to really employ. And then I think really helping them understand, I know when I say it's the disease, but that's why I go back to any way that I can get the message to somebody to say, when you're looking at your mom or you're looking at your dad, I want you to look right through and imagine what's happening to the brain. We cannot lose sight that this is a disease of the brain. And I think families do because they're caught up in the day-to-day stress and overwhelm of providing that care. I'm getting the look. Any other questions? Anything else I can answer? We have 2 more minutes. I hardly know what to do. 2 more minutes. Yes?
My husband has Parkinson's disease, and he recently had the deep brain stimulation. How do I convince him that sometimes he thinks he's saying things where you can hear them, and whatever, without getting on his nerve by saying,
So first of all, it would depend on how advanced the dementia is related to his Parkinson's.
It's not dementia, it's just that it's a matter of he's not realizing things, and he just, you know, the whole idea of communicating both sides. How do you get the person to speak up or whatever without getting you frustrated enough to go, you want to take the person's problem?
Yeah, I think choking is probably not an option. I'm not sure, but I think that they frown on that. But I do think that the most important thing is when you start saying to yourself, no matter what condition you're taking care of, how do I get them to? It's the wrong question. It's kind of like, how do I get somebody to be nicer, to be kinder? You know, it just, you have to look at, okay, what strategies can I do to better cope with that behavior? So it really comes back to you. You know, if you're right at the last minute, like I don't even know what he's saying and I can't ask him again because he'll get mad and I'll be frustrated. It comes up, without knowing a specific example, comes up to what strategies can I use? How can I understand what he's asking me or saying to me without saying, I didn't hear you again. You think you're saying this. Like we think if we lay it out there in some rational term, suddenly they're going to go, oh, I get it. You're right. So my challenge to you would be, anytime you start a sentence with, how do I get him to, I would flip it around and go, how do I make a change in how I manage the communication issue between the two of us? And I would have to know a little more details to maybe give you something a little more specific than that.
We see or hear or arguably, some people say it's Parkinson's disease and some people say it's Parkinsonism. And what is the difference?
It's because we like words and terms and in the professional world. Actually, I think when you're talking about Parkinson's disease, it's the same thing like talking about Alzheimer's disease. You know, we almost get rid of the disease word and we come up with a shortened phrase, like we'll say Alzheimer's. Well, then that becomes that misnomer of, well, is Alzheimer's dementia? But you talk about Alzheimer's disease being a cause for dementia, I think the same thing holds true with Parkinson's. There's a Parkinson's disease. Then what is the comorbid conditions that you're describing? And sometimes people will say Parkinsonism because what they're talking about is the cluster of symptoms, the shuffling gait, the changes in their face, the higher incidence of depression. They're talking about, this all goes into Parkinsonism. But again, at the end of the day, it's a disease. It's Parkinson's disease that carries with it these other symptoms. You had a question back there.
My question is on the family members that struggle with anger and aggression, and they have a good understanding of the disease, but the one caregiver that's providing the care has to take the anger and the aggression from the person with dementia. How do you help them keep their equanimity and, deal with it on a day-to-day basis?
So if I heard all of your question, it was really about if the brunt of the anger and the aggression is being directed at one particular care provider, how do you help them support that. So, when we talk about anger and aggression, simply understanding where it comes from doesn't make management any easier. And there's also a safety component. Nobody is saying that if you're the care provider or the family member, that just because you understand that they are aggressive and they're lashing out because they're scared or because they're confused or whatever, doesn't change the fact that you still have to be safe. Safe physically, safe emotionally. So my push is always to look at how can we better manage the aggression and the agitation. And sometimes this is where a combination of behavioral strategies and medication can be very helpful. I often tell people be very open-minded to the medications, because sometimes we get into a little box and we go, oh, you can't use this medicine because it has a black box warning, then that could cause this, so it's out. I think, in medicine, the challenge is to really be, the art of good medicine is to have the right blend. Do you have the right environment, the right education, the right behavioral tools, the right medications? Are you does the person have adequate sleep? So you really have to be looking at all levels. Are you managing them in an integrated way? Because that's your best strategy for managing the agitation and the aggression. And the other part is, if it's directed at the one care provider, it might be at the times when you have to really provide those intrusive things, bathing, toileting, that you look for. If they're going to lash out at me for whatever reasons that I can't identify, I'm going to have somebody else do that task. Because sometimes it's a trigger. And particularly like in organizations where you don't know. If, in this organization, you have Holocaust survivors. In other organizations, you might have people who are exposed to all kinds of trauma. That sits in the long-term memory, things that we can't possibly know what those triggers are to reignite that trauma. And then people go into a protective mode. And that's the other layer of dealing with seniors, that we don't know always all of their history. So I think those would be a couple things that I would suggest. Okay, I thank you all very much, and I apologize again for the delayed start.